Assalamu alaikum wa rahmatullahi wa barakatuh. It's my honor to participate in the NAFLD conference, and I'd like to express my gratitude to my dear professors for inviting me to present my talk. My talk today will be about non-alcoholic fatty liver disease and chronic kidney disease, or the recently suggested name, the NAFLD, or metabolic associated fatty liver disease, and CKD. Non-alcoholic fatty liver disease, or NAFLD, according to the new suggested name, is becoming the most prevalent cause of chronic liver disease worldwide. The NAFLD is characterized by the accumulation of lipid droplets in the liver cell with exclusion of other causes of chronic liver disease. Actually, the clinical spectrum of NAFLD and the natural history varies and passes through different stages, starting from simple steatosis, non-alcoholic steatohepatitis, fibrosis with its different grades, and cirrhosis, and finally the complication of cirrhosis, which is hepatocellular carcinoma. But actually, this scenario may differ from patient to patient due to presence of some persons who are known to be rapid fibrosers, and the progression may be more rapid, starting from simple steatosis into severe fibrosis without passing into NASH, and the more recently debate about the progression from simple steatosis to hepatocellular carcinoma. The diagnosis of NAFLD, the gold standard mode for diagnosis is the liver biopsy, but this is an invasive method, and due to the patchy nature of the disease, it may give false negative results. So other methods are available with different sensitivities and specificities, including the ultrasound, the MRI, and the elastography. Also, we have a group of serological tests or some complicated equations to predict and to stratify the presence of NAFLD in susceptible personnel. Actually, NAFLD is the hepatic manifestations of metabolic syndrome, which include insulin resistance, visceral obesity, hypertension, and dyslipidemia. The association of NAFLD with several other diseases has gained increased interest during the recent years, especially its association with CKD, or chronic kidney disease. If there is a link between NAFLD and CKD, this question has emerged to the scientific community recently. Actually, large number of longitudinal and cross-sectional studies showed an association between NAFLD and CKD, and the prevalence of CKD in patients with NAFLD reached up to 55% compared to 35% among non-NAFLD patients. A large number of these studies with different modalities and different study designs have confirmed this finding. But the question now, is it an association or a causal relationship? Actually, up to date, this question has no definite, sharp answer. Different authors consider this relation just an association due to that NAFLD and the CKD share many cardiometabolic risk factors like insulin resistance, hypertension, dyslipidemia, and so on. On the other hand, other authors and the different studies reported that NAFLD was associated independently with the presence and the severity of chronic kidney disease, even after adjusting for traditional cardiometabolic risk factors. In a retrospective study in Japan, this study was run for more than 5,000 patients with NAFLD without CKD at baseline. The cumulative rate of CKD was about 3% at the 5th year of follow-up and exceeding 10% at the 10 years follow-up, with an annual incidence of 1.2%. Additionally, these studies showed a graded positive relationship between the histological severity of NAFLD and the kidney disease, independent of several risk factors for CKD, including the metabolic syndrome features. That is to say, patients with NAFLD and fibrosis have severe form of CKD compared to patients with NASH, and the patients with NASH were more severe than patients with simple steatosis. In liver transplant recipient patients who underwent liver transplantation for NAFLD have been found to have worse kidney function after transplantation compared to other indications of liver transplantation. Even renal transplant recipient patients in a study run on over 73 renal transplant recipients with functioning graft for more than 1 year liver stiffness have been evaluated in these patients using transient elastography. The NAFLD was present in about 57% of renal transplant recipient patients, and the severity of liver steatosis was positively correlated with serum creatinine and negatively correlated with the estimated GFR. Also, the severity of liver fibrosis was positively correlated with serum creatinine, serum iron, and CRP, indicating a more severe form of NAFLD in these patients. There also have been a relationship to the liver histology. In an 80 patient with biopsy-proven NASH, there is a significant difference in the severity of CKD with different stages of NASH fibrosis stage. Now, it's an association or a causal relationship. Actually, it's growingly accepted that it's a causal relationship rather than just an association. What is the pathophysiology behind this link? Actually, the main pathophysiological mechanism is not fully understood up to date, but the presence of inflamed visceral adipose tissue with the liberated cytokines from these cells and these adiposities, the insulin resistance, and the hepatocyte inflammation with the atherogenic dyslipidemia all interplay to precipitate the renal insult in a patient with NAFLD. This is not the story. Also, it has been found that the kidney itself, with its pathology, may alter the gut microbiota with the presence of uremic toxins and the glucocorticoid metabolism changes may precipitate NAFLD formation. So it's a bidirectional relationship. How can we predict the presence of NAFLD among patients with CKD? Actually, some non-invasive predictors have been supposed, and the recently published paper in 2020 says that the body mass index, renal function in the form of eGFR, triglyceride glucose index, serum ALT, and hemoglobin level were the positive predictor for the presence of NAFLD among patients with CKD, and Cho et al. Generating a prediction model for this aim. On the opposite side, how can we predict the presence of CKD among NAFLD patients? A recent meta-analysis reported that the presence and the severity of NAFLD are independently linked to the increased risk and the severity of CKD. And the presence and the advanced liver fibrosis detected by NAFLD fibrosis score or the FIB-4 score are independently predictor for the presence of CKD among individuals with NAFLD, with the FIB-4 score was the strongest predictor with an odd ratio exceeding 2. Recently, an Egyptian study published 2020 in Ain Shams University, they used the renal resistive index to predict the presence of CKD among NAFLD patients, and they concluded that the renal resistive index was significantly positively correlated with serum creatinine and negatively correlated with the estimated GFR. Also, the recently interesting microRNAs which gained interest in the medical field in the last years have been studied to detect the association with the formation of liver steatosis and the CKD. Actually, we have an own experience in Alexandria University. We examined the microRNA 192 in the plasma of 3 groups, group of NAFLD only, group of NAFLD with type 2 diabetes, and type 2 diabetes only. In the subgroup analysis, we analyzed the data of the group of only NAFLD patients, which were 50 patients actually. We evaluated the presence of CKD based in the urinary albumin-creatinine ratio and the eGFR. We found that the microRNA expression in a patient with NAFLD and the CKD was higher than the expression in patient with NAFLD without CKD. And this value showed a very good sensitivity and specificity using the log curve analysis. Also, the hepatorenal index was measured in these patients, and the value of hepatorenal index was significantly higher in patients with NAFLD and CKD compared to NAFLD without CKD. And this also had a good performance in log curve analysis. And there is also a positive correlation between the microRNA level, the hepatorenal index with different study parameters, specifically the urinary albumin-creatinine ratio and the eGFR. This work has been recently published in the Clinical Diabetology Journal just a few days ago. Shall we screen for CKD among NAFLD patients? In general population, the current guidelines do not recommend routine screening for CKD in absence of traditional risk factors for CKD. However, based on the current data about the association between NAFLD and CKD, individuals with NAFLD should be screened for CKD, even in the absence of classical risk factors, particularly if NASH and advanced fibrosis are suspected. Why? Why this screening is important? The early recognition of impaired kidney function in NAFLD may allow drug dosage adjustment, especially in the obesity-associated comorbidities. In addition, NAFLD development after renal transplantation may precipitate graft failure, so the follow-up of patients is very important. This will improve the morbidity and the mortality rates in susceptible individuals. What are the therapeutic implications which are running nowadays about this point of science? The knowledge of the pathophysiological mechanism behind the NAFLD formation has opened the door for multiple clinical trials with experimental medication or drug for treating both the NAFLD and CKD in susceptible individuals. And this graph shows us how many the studies are running nowadays in different phases. These agents are thought to protect from renal inflammation and the kidney fibrosis. The anti-diabetic drugs, GLP-1 receptor agonists and the SGLT2 inhibitors are found to be beneficial for renal function protection, and they are currently tested for this aspect. Lifestyle intervention, specifically smoking, which is known to increase the risk and the progression of CKD, have to be stopped. Statins and the ARBs, specifically telmisartan, also improve the liver and the renal function in NAFLD patients. Other agents like pentoxifillin, TZDs, and the polyunsaturated fatty acid are needed for clinical trials. My take-home message: NAFLD is associated with CKD irrespective to the other cardiovascular risk factors. The severity of liver fibrosis and steatosis correlates with the degree of renal insult. The pathophysiological link between NAFLD and CKD need further clarification. Screening for CKD in patients with NAFLD is recommended. Is NAFLD associated with a specific type of kidney disease? This is currently unknown, and this is an unanswered question is need to be investigated more in the clinical studies. And thank you.
شكرا دكتور سام.